Your journey to a stronger heart starts with knowing your risk, conversations with your doctor, and preventative screenings. Learn more in this educational seminar provided by Dr. Todd Brophy, non invasive cardiologist at Mercer Health.
Here, you're looking at a total share of cardiovascular death, and it's probably a little small in the back, but the red bar just tells you that heart disease is number one. So almost a third of all deaths are from heart disease. That's actually 50% more than cancer, which is number two. So heart disease is far and away the leading cause of death. We've made major progress since back in the 50s, so it used to be over 50% at that time. So over the last handful of decades, you get introduction of bypass, more medications, aspirin, etc., eventually stenting, making progress, but still the highest cause of death. This was published a couple of years ago, so actually the American Heart Association put out a bulletin saying that rural outcomes are far worse. That's true of all-cause mortality, but also with heart disease as well. So at least about 20 or 30 years ago, you can see this gap. In orange, heart disease stays a little higher than in blue, which would be the urban metropolitan areas. Probably at least part of that has to be due to access to hospitals that have surgeons, cath labs, stenting, all those things. So we'll talk more about this later, but Dr. Amran handed me the newspaper the first 5 minutes I was in the building at Mercer Health with this article, and then I had 1,000 friends text it to me as well. So on this graphic on the far right side, Mercer County, number one in the state. We know it's preventable, and also we know we can do better because there's other counties that are literally half our rate. So there's a lot that we can do to reduce heart disease here. So a couple of key points that we're going to leave here tonight with, if nothing else. Heart disease, number one cause of death. Local rates are far too high. That last stat was for working age adults, and prevention is possible. So we'll try to keep it pretty high level, but we'll go over heart disease in general, symptoms you can expect from heart disease, different treatments available, and then we're going to try to focus the majority of this on prevention. All right, so for heart disease, in general, there's lots of heart diseases, different things like heart failure, et cetera, but for heart disease, we generally mean artery disease and blockages. So we typically have 3 main arteries on the heart, 2 on the left, 1 on the right. And when people have heart disease, you have these gradual cholesterol plaques that build up and narrow the vessel. So think about it like plumbing and corrosion. We're going to narrow that vessel down. There are a couple of key things that can happen. Some of them happen quick and some happen over a longer period of time. So a different way of looking at this, when we're young, arteries are nice and smooth, nothing in the walls, just the way they're supposed to look. Over time, we have cholesterol build up. These deposits gradually grow and grow. You're going to narrow the actual open part of the vessel called the lumen. So that alone can cause gradual starvation of blood flow to the heart. So if your heart is asking for 80% of maximum blood flow, but you've got a narrowing, only letting down 50%, that's that imbalance. That's what's going to cause chest pain, shortness of breath, all the symptoms that we worry about. And then the key thing we think about too is a heart attack. So what happens there is that the surface of this cholesterol rips open. When that's exposed to the bloodstream, it wants to form a clot. But that clot doesn't know that it's in the main artery of the heart. It seals off entirely, and that's your heart attack. The same thing in the brain would be a stroke, okay? We'll talk more about this later, but everything we want to do for prevention, healthy lifestyle, medications, etc., we want to shift everything as best we can back to this side. And with the right treatments, we actually can shrink blockages and plaques that are already there. So to go through some of the symptoms, heart disease is tough because the symptoms can be somewhat variable. A lot of things with the heart can feel like something else. If you're short of breath, is that your heart or is that your lungs, right? So things we think about for an acute heart attack, typically we think about chest pain and pressure. So sometimes it's tightness or heaviness in the chest. Sometimes that'll radiate to your arms, your shoulders, up to your neck. Sometimes people have more nausea or more shortness of breath predominant symptoms. And the tough thing is that we know that women tend to present atypically. So women are more likely to have just nausea and isolation rather than chest pressure and everything else. The other thing would be in the chronic setting, when you have that chronic narrowing, that chronic starvation of blood flow to the heart, you might be having more symptoms with activity and exercise. So you're climbing the stairs, you're having a little more chest pressure or tightness or just feeling short of breath. And it's not as easy as it was 1 month ago, 2 months ago. So those symptoms can be kind of insidious and progress slowly. But that's why we have to be more attuned to what to watch for. If we think someone's having a heart attack or we think they've got severe heart disease from other testing, stress tests, et cetera, what are the key procedures to do a heart catheterization? So this is not performed here. This is something that we have to refer outside the area for. But typically, we'll sneak a small wire and tube up the artery from either the wrist or the groin. We follow the vessel all the way back to the heart as the highway back to the heart. We line up that tube to inject contrast dye down the arteries. So when we inject, we're gonna highlight the arteries. You're gonna see a whole tree kind of coming out like rivers on a map here, okay? So this is an example of normal, smooth arteries, and this is an example on the left side of the heart. Now, this looks worse. So here's that same artery for someone else on the left side. They're injecting here. You see some lumpy, bumpy things here, but then you see a total gap here, right? So this person has a gap in flow here. They do have a little bit more flow down here, which is called collateral filling, but clearly this is an area of concern. Here on this side, they've injected and it just stumps off and stops entirely, okay? Depending on the degree of blockage, how many vessels, the characteristics of the blockage, sometimes you can get away with just doing medications if it's a minor blockage. If it's a serious blockage or if it's during a heart attack, we think more about stents and bypass surgery. That wasn't obvious enough. So for those treatments, the key couple of things we talked about is restoring blood flow or revascularization done through either stenting or open heart surgery bypass. We only actually fix blockages typically that are 70% blocked or worse. So there's good data saying that if you fix anything before then, you're not really doing any favors to the patient and you're putting them at risk of complications and other side effects. So 70% blocked or worse. Whether you get stents or bypass or hopefully nothing, medical management is going to be a key part of this. And so we'll talk more about this later. We all know more about aspirin. It's more common. It's been around a long time. There are separate medications we use just for chest pain relief, and then certainly targeting risk factors like blood pressure and cholesterol. So if I showed you the heart catheterization earlier with that branching pattern of the arteries, this is what a stent would look like. So again, you've got a severe narrowing here. You're limiting blood flow down to the muscle of the heart. When they do a stent, they sneak a wire past that blockage. There's a metal scaffolding. So the stent's just a metal scaffolding that's got some special drug on it that helps prevent repeat heart attacks. It's all crimped down on a small, tiny balloon. They snake it past that area of blockage. They inflate that balloon to push everything back out of the way. When they deflate the balloon, that metal scaffolding, that stent, stays behind. They take out the wires, take out the balloons. The stent stays there with good medicine. Hopefully stays open forever, okay? As opposed to bypass, we're doing open heart surgery. We're going to use sometimes your own arteries from your chest wall, sometimes taking veins out of your legs. But the whole point is you've got enough blockages in all the vessels or the blockages are in the wrong locations where bypass is a better option. And they will literally take your vessels, either from where they normally take off from your arteries and plug it in downstream of the blockage, or they'll actually take the veins out of your leg, for example, plug it in somewhere like here, same idea, plug it in downstream of the blockage. For those medications we talked about, aspirin's really key. There are some other medications that if you have a stent or have bypass or a heart attack, you'll pair with that. Beta blockers are medications that are really common. They treat blood pressure, they treat heart rate, but they help hearts recover after blockages from that chronic damage. We're going to treat blood pressure. We're going to treat cholesterol and diabetes. Nitrates are medications that help dilate the arteries to have less chest pain. So Not everyone needs nitrates, but for the right people, it's a good tool. And then one of the most important things would be tobacco cessation. Smoking and tobacco use in general promotes buildup faster than almost anything else. And we'll talk more about that at length. Getting back to the figure from earlier about this urban versus rural divide, this is at least part of the issue, okay? It doesn't look that far on Google Maps, but if you're having a heart attack and you're in the emergency department, an hour is a long time to go, okay? So we've got an hour to Lima or Dayton, longer to Columbus. For specialized things, it's 3.5 to Cleveland. So the key things for here, diagnose things early, catch it early enough. We can do this electively, not emergently, okay? So now to the main topic here of prevention. As I mentioned earlier, we have this schematic of how arteries can build up blockages. Everything that we want to do, healthy lifestyle and medications, we always want to shift that risk back towards the left. So your doctors might talk to you about blood pressure, diabetes medications, statins, etc. But the key thing is that if we actually control risk factors well enough, lower cholesterol well enough, not only can we prevent this from growing worse, we actually have proven that you can shrink it backwards and actually shrink those blockages and restore a greater amount of blood flow. So the American Heart Association put out this construct a couple of years ago called Life's Essential 8. So kind of 8 key domains, the thought being that if we take care of these 8 things, then that's 90% of heart disease and prevention. Okay. In general, I'll say I recommend the American Heart Association and another website called CardioSmart for looking up anything about heart disease. If you just Google things wildly, you can find all sorts of answers. Those are 2 sites that I think are totally reasonable and written by cardiologists. So I'm happy to explain more about that later. So we go through those 8 domains stepwise. So the first one, eating better. We all hear about eating better, but it's always harder to do. In general, if you look at this figure, fruits, veggies, nuts, whole grains, eat those, focus on those. Lean proteins too. There's some other data saying maybe a plant-based diet is a little more beneficial. We know the Mediterranean diet is helpful as well. We talk about olive oil, avocado oils that are liquid at room temperature. I tell patients in the clinic, if it's solid at room temperature, butter, lard, grease, we don't want that in our arteries. Try to avoid those as best you can. I'm not going to say you can never have a piece of toast with butter, but in general, try your best to avoid those kinds of fats. Along with that is red meat. I was in North Carolina, which is the pork capital. I was in Texas, which is a brisket capital. Both pork and beef are red meat. And the reason red meat we think is worse, because even if you have equal amounts of cholesterol and saturated fat, they did a study up at Cleveland Clinic. When your gut breaks down red meat, it makes this extra chemical called TMAO. You don't have to remember that. But what it does, that promotes more buildup on the arteries faster than you'd expect for the same amount of cholesterol, amount of saturated fat in your diet. So that chemical that's only seen with red meat breakdown, that's part of why we think red meat's a little worse for you than chicken, fish, etc. And that's a controversial thing to say that I hear sometimes. Getting active with exercise. In general, the American Heart Association would recommend you're going to do exercise 30 minutes, 5 days a week for a total of 150 in a week. If you're doing more intensive exercise, if you're swimming laps, doing whatever, then they say more like 75. So it's all about kind of the amount of effort. So if you're working harder for a shorter period, that's fine. The other thing I'll say is there was a study that came out this past fall that's called kind of the Weekend Warrior study. So if you say, hey, I can't do 5 days a week, but I can do Saturday and Sunday, or I can do 2 days of whatever, that actually shows you a lot of the same health benefits. So if you can only give 2 days, start there. Anything counts. But use this as a way to say, you want to aspire to 5 days, but starting anywhere is helpful, okay? I mentioned tobacco cessation earlier. It's the number one thing we can think about for heart disease, stroke, aortic disease, aneurysms, things like this. What we know is that most people have to try to quit 7 times before they're successful, even with patches, gums, other medications. But it's critically important As you cut back on your tobacco use, your lung cancer risk does decrease. But the heart's not that forgiving. It's kind of all or none. If you cut back from 20 cigarettes to 2 cigarettes, your heart attack risk is not that different. You've really got to get down to truly 0 cigarettes in a day. One drop kind of poisons the whole well on this one. So really, getting truly to 0 is the way to go. It's never too late to quit. We can talk about that in clinic. All your doctors and Mercer Health or other providers are happy to talk about this. Sleep is less directly tied to heart disease, but is related to other risk factors and other general heart health. So the key thing with sleep we think about the most is sleep apnea. So with sleep apnea, typically someone's falling asleep, the back of the throat gets a little too relaxed, it goes back, obstructs and blocks your airway while you're asleep. And so to imagine that you kind of get startled or gasped awake, things like that. If someone snuck into your room every night with a pillow and kind of suffocated you for a brief minute, did that 100 times per night, that's what sleep apnea is doing. It leads to high blood pressure, it leads to more AFib, it leads to more diabetes. So AFib by itself is a whole other talk that we don't want to get into, but blood pressure and diabetes, again, directly tied to heart disease. For a healthy body weight, the recommended BMI or body mass index is 18.5 to 24.9 or 25. The body mass index, all that is taking your weight and kind of averaging it or indexing it to your height. So, if someone's 5'2", we give them a different scale than someone who's 6'2". The other way we look at this is by waist circumference. So there's good data that some people just carry more weight around their midsection. We call that central adiposity. That's directly related to high cholesterol, more type 2 diabetes, more heart disease. So women, we like the waist to be 35 inches or less, or men 40 inches or less to reduce heart disease risk. The thing with weight loss, it's going to improve all facets of health. Less heart disease, better blood pressure, less diabetes, better cholesterol, less knee replacements, less hips, breathe easier when you're exercising, all those things. There are lots of new medications that you see ads on TV for and everything else. If there's something that's right for you, talk to your doctor. They're incredibly safe, very effective. There are meds in that family that have been out on the market for 20 years. I think they're very good medicines. They also show that they actually reduce your heart disease risk directly. So even in patients who don't have heart disease, maybe they just have obesity and high blood pressure, they do reduce your heart disease risk as well, preventing future heart attacks and strokes. For number 6 here, lowering cholesterol. So I mentioned a couple times already, but cholesterol is what is building up in the vessel to cause that narrowing and also promoting that risk of heart attack. When we talk about cholesterol, everyone thinks they have a good cholesterol, or maybe it's just a little bad. But it's a really personalized thing that we have to talk about. So your cholesterol by the number might be okay for the average person, but if you've had a heart attack and a stroke, that cholesterol is too high for you. You've already had events. We need to really reduce that risk. So again, in general, anyone kind of coming through the office, we like the LDL, bad cholesterol, under 100. If there's nothing else you leave her with, LDL is the bad one. Everything else they give you on that result, ignore most of it. Let us figure that out. The LDL is the bad one. We like that less than 100. If someone's had a heart attack or stroke, or they've got diabetes, maybe they've had a stent, one of those things, we actually want the LDL cholesterol less than 70. If you've had multiple of those things, we actually want it less than 55, which sounds really low. But if you already had heart attacks, stents, blockages, you really can't afford another insult. What we know from all the studies is that when we get the LDL, bad cholesterol, less than 70, especially less than 50, we actually can reabsorb those cholesterol plaques. They've done studies where they go in the vessel, like on a heart catheterization, but they actually use a small ultrasound camera, and they've seen that these plaques, after 6 months, a year, etc., do shrink and reabsorb. Okay? I get a lot of questions about number 2 on here. So heart healthy lifestyle, of course. I get a lot of questions about statins. Statins are incredibly beneficial medications. There are questions about side effects often. Side effects are rare. I think these are some of the most important heart medications, probably one of the most important medications overall. If someone truly has an issue with these medications where they have an intolerance, they can't take it, there's been a bit of a renaissance where now we have new medications available. Some are pills, some are injectable, but regardless, there is some combination of things we can do to control your cholesterol, reduce your heart risk. And if you have questions on any of that, obviously talk to your doctors, talk to one of us, and we'd be happy to talk about it. So a different way we think about the heart disease risk is with coronary artery calcification. So just like in the other picture, we have that yellow cholesterol buildup. You might have heard heart disease called hardening of the arteries in the past. That's because over time, this yellow cholesterol does get hardened with bits of calcium. What we know is that calcium absorbs X-rays, and so it shows up bright white on things like X-rays and CTs. So we can use that to our knowledge to say, okay, if we do a special heart CT and sync it up with the heartbeat, can we find any spots of calcium on the arteries in that scan that would tell us indirectly if there's calcium, there's a cholesterol problem? So this is an example from the Cleveland Clinic's website. And these kind of images, you're kind of cutting through someone like a loaf of bread this way, looking up from their feet. This is the heart in the middle. It should be all shades of gray. Things that are bright white are full of calcium. So here's the spinal column in the back, ribs in the front. So you can see how this person, no white spots on the heart, nothing to worry about, score of 0. It's great. Here's a score of 29. There's one little white spot here. Here's a moderately high score of 250 with several white spots. And this is a score that's over 1,000, severely elevated. You can see a dense white pipe where the left main artery should be. You also can see buildup on their aorta, putting them at risk for aneurysm. So this is an incredibly helpful, powerful test. Right now, people are driving a good distance to have this done. Thanks to the support of Mercer Health, we're going to have these available here, I'm told soon, so hopefully by the next month. We're actually going to go one step further. We're going to do CT coronary angiograms. So this is different than the last scan. The last scan is quick, 5 minutes, outpatient. This test is a little more involved. We actually give contrast dye in the IV, but it's a high resolution scan. So instead of just saying, yes, no, is there calcium? I can look and say, well, yeah, there's calcium, but it's less than 25% blocked, nothing to worry about. We can just watch this for now with good medications. Or I can say, we've got something serious. This is over 50% blocked. I think we need a heart catheterization. Let's do this now on our own timeline instead of making it an emergency later. So this is something that will be available in the next few months as well. I think we're going to be the only ones offering this as far as Dayton or Lima or even further, actually north. So I think this would be critically important. If someone's going to drive an hour or 2 hours away to go to the cath lab, the thought is we know what they're getting. We know where the blockage is. They're going there for a fix, not for the diagnosis. We should be able to make the diagnosis here.
Yep. The emergency provider step by you there.
We are starting them with elective outpatients first, and then we will consider expanding that later. Initially, though, we're going to treat it more like a stress test where it's elective just with outpatient scheduling. To do it on an urgent basis gets tougher with scheduling and staffing. So, because with this test, you actually have a nurse that has to give medication to control the heart rate. This test is synced up with the heart rate. The heart's always moving, right? And so if you imagine taking a picture of someone running by you, it's going to be blurry. So the key thing with this is we take the picture at just the right time in the heart cycle, and we have to give the medication to slow the heart rate down, because the slower the heart rate is, the heart pumps, and then it's got more time between beats for us to take that picture. So to do it overnight, emergently at 2 a.m., I would have to ask you to come in and give the medications, probably, Jill. So we're going to start with outpatients, and we'll see how it goes from there. But good question. For blood sugars and diabetes, we know it's important for heart health. Again, it promotes buildup in the arteries just like cholesterol and everything else. With blood sugars, though, as you can see on that far side of the diagram, there's so much more, right? It's high risk of strokes, high risk of vision loss from retinal disease, higher risk of kidney disease and progressing towards dialysis, higher risk of vascular disease in your extremities, including your legs, amputations, everything else. Diabetes is a terrible illness in general, but again, in the last 5 or 10 years, we've got a bunch of new medications that are incredibly effective, not only at lowering your blood sugar, but lowering the risk of things like heart failure, lowering the risk of things like blockages and heart attacks. And then the last one on this list of 8 things is controlling the blood pressure. So blood pressure gets a little controversial for some people because it seems like we change our goal every couple of years, but I promise there's good reason for that. We used to say less than 140 was a good number. And as I'll tell you in a second, we say we got to get closer to 120. When we talk about checking blood pressure, we typically say sit still 5 or 10 minutes, feet flat on the floor. If you have a cuff, hopefully it's automated. Up here on the arms, probably better than the ones on the wrist, but sit still, hit the start button, let it get the recording. One number doesn't make a diagnosis, but if you have a trend of high numbers, we should know about that. Now, I mentioned 120 is better. There was a study that came out in 2015 called the SPRINT trial, had over 9,000 patients in it. And they said, what should we do? Should we target that top number to 120 or 140? The answer is 120 resoundingly. So less cardiovascular death, fewer heart attacks, fewer strokes, less congestive heart failure. So a 25% reduction in those things. They followed those same people up a couple more years. They actually have less evidence of cognitive decline and impairment, so kind of early signs of dementia, also decreased by 20%. The most common reason for dementia is vascular dementia, which means you're having many strokes, TIAs, and strokes that just add up over time to worsen the brain's function and scar things down. So this is one of the first things we've shown that we actually can maybe bend the curve and reduce the risk of things like dementia as well. When we treat blood pressure, we know there's lots of medications people are familiar with. We really got to watch on the salt intake. Sodium makes you retain fluid, so your pipes are just more full to start with, but also it dials up the hormones at the kidney level that create the blood pressure. So watching them for the salt is key. The one diet plan that's been tested in this is called the DASH diet. And so the highlights are over here on this far side. In general though, low salt, looking for high potassium foods. So plenty of fruits and vegetables, whole grains, low fat dairy, skim milk, etc. Fish, and then poultry rather than red meats. This has shown significant improvement. This kind of a diet can be as good as a medication or get you off a medication. So these are really important steps to take. So that was a quick run through of prevention. As you kind of saw, there's many different avenues you have to pursue to reduce your risk. These effects go beyond just heart health. Again, it's joint health, it's brain health, it's breathing health. So talk to your doctor, make a plan about what you want to work on next. This Life Essential 8, if you just search that in Google, it'll come up right away. They have information, pamphlets, brochures, things you can print out, things you can work through to kind of make your own plan or think about areas of emphasis for you. So back to the key points to hammer these one more time. Heart disease is the number one cause of death. Locally, our early onset working age adult rate of death is far too high, but we know there's ways to do adequate prevention. With being in a rural area, we know the prevention is even more important than other areas.